This video is part of our pain series. It discusses, do scan results always show us the big picture? And how can we interpret those scan results in regards to the symptoms and sensations that we're feeling? My name's Ali, I'm one of the physios from treatmyachilles.com. Treat My Achilles is an online virtual physiotherapy platform treating any type of Achilles problems. If you would like to find more about our services or book an appointment, please see the information below this video. So this video is part of our pain series. In this video, we're discussing, do scan results always tell us the biggest picture? In one of the videos in this series, there was an interview with Dr. Caroline Marlowe, who's a psychologist specialising in pain and injury, and she was discussing why pain doesn't always link with the severity of the injury, doesn't link with the amount of damage or problems that are going on in that injury. Actually, pain just doesn't correlate to harm at all. So how is a scan actually useful when we're thinking about this in regards to an Achilles tendinopathy? Well, the scans we're typically talking about tend to be those that include soft tissue, so not just bone like an X-ray, ones that may show pictures of ligaments, tendons, muscles, and the bones themselves, and any other structures. So those sorts of scans tend to be an MRI or really an ultrasound scan. So what do they tell us? Well, they can tell us structural change. So that structural change is what is going on with those things I've just listed. Were there any signs of inflammation? Are there any signs of thickening of an Achilles tendon? Are there any signs of changes to the structure of the collagen fibres or the amount of water content in a tendon? These are the sorts of things that you might see on a scan. And there have been previous videos on Treat My Achilles that will have gone into more detail about those. So let's think about what a scan means in regards to our symptoms. So I like to use an analogy of my holiday photo. So here's my holiday photo of me and my husband and my kids smiling away, having a really beautiful destination in the background. So that looks great on the surface, but actually what if I told you that just prior to that photo, one of my kids had a massive tantrum, the other had fallen down and hurt themselves, but my husband and I had had words, the beautiful surroundings behind us, there'd just been a horrendous weather and we hadn't been able to go out and see them for the last 2 days. Well, you don't know any of those thoughts or any of those feelings or any of the belief patterns that we've got around those by looking at that image of us smiling on holiday. Well, that's the same as a scan. Those scans show those structural changes, but they don't tell us what sensation we're getting from those structural changes. So you might be those structural changes might not relate to a pain driver at all. It might not be where or what is happening when you're feeling a sensation. So, well, what do we do? Well, lots and lots of treatments have been targeted at changing that structural change. Those sorts of treatments, back in the past might have been some more hands-on friction-based therapies. They might be using ultrasound machines or laser machines, or they might be things that are really targeting that pathology, such as injection therapy or surgery. Well, all of those sorts of things are treating the pathology, they're not treating the symptoms. So when we assess somebody at Treat My Achilles, we need to know lots of information. How do you use your tendon normally? What would you like to do with it in the future? How is it affecting you now? And what sorts of symptoms are you feeling? Well, this means we can start to draw a bigger picture. And if you have scan results, you don't need them, we can look at those as well and we can summarise what's going on. We really do know that what is shown on the scan doesn't relate to pain, and we also have quite a few patients who have had scans because their pain's been going on quite a long time and there hasn't been any sign of an Achilles tendinopathy then. So why on earth are they getting Achilles pain? Well, that's something that Hanlon et al. Have looked at and have studied in greater detail. So Hanlon et al. In 2021 took a large group of people with Achilles tendinopathies, and it was about 145 people, and they did a large amount of tests. So they did do ultrasound scans and other types. They also looked at physical ability, so could they do calf raises, what can they do, and they also looked at what their beliefs were and whether there was any thought patterns or worries or things going on in their lives that means that they didn't really want to use that Achilles tendon anymore because they were frightened of what is going on, or whether that would mean more damage or it hurt so much they weren't able to do the things they wanted to do. And he decided that, yeah, loading it is our traditional way of looking at things, the way that we now know is one of the best research or evidence-based treatments for an Achilles tendinopathy. And by loading it, we're talking about a graduated rehab program that we have discussed before at treatmyachilles.com. But he also said, well, if you just load it and you don't do anything else with these people, 60% get better, 40% it doesn't really resolve all of it because it doesn't treat the complexity of pain. Now, Dr. Caroline Marlowe discussed a little bit more about the complexity of pain, so if you haven't seen that video, please look in the link below and have a look at that before we start. So he split his findings into 3 groups. The 2 largest groups were the activity dominant and what he called the biopsychosocial dominant group. And then there was a smaller 3rd group that was related to structure. So if we looked at the activity dominant group, these were the ones that were brilliant at doing the loading program. They were ones that when they filled out their quality of life questionnaires, they was very mild. They weren't really concerned by the pain. They also knew on the scan that there was less thickening there. There was least fear of movement. They were also the youngest, and they also had the lowest body mass index. So they weren't generally obese. So they managed really well with the standard program of this is how we do it, this is how we load it, and this is how we progress it on. And they got better. So they were the largest group, 67 out of the 145. Then interestingly, a very similar sized group, so 56 out of that 145, were put in the psychosocial group. And they had the worst symptoms out of the 3 groups, and those worst symptoms were indicated with poor quality of life on a questionnaire. But actually the scan changes were the same as the activity dominant group, very little thickening. So this group had the greatest amount of fear about what might be happening, the greatest amount of fear in regards to using the tendon and what pain might mean, what it means for the future, what I can do, what I can't do, it's going to deteriorate and get worse. When they looked at the demographics of this group, it was quite interesting to note that the majority, 66%, were female, and quite a lot of this group were obese. But what really drove this was the beliefs about the fear in loading and the damage. So therefore, just loading it and giving people exercises to load it and load it and load it, and not addressing these beliefs and this fear isn't successful with this group of people. Going much slower, doing exercises more little and often as the day goes on, progressing them more slowly, but really working on how does this pain impact you? What can't you do? Why do you think this is happening? How can we help you build more confidence in what's going on? Well, this is such normal feelings to have when you have an injury, particularly an injury that stops you doing the things that you want to do, an injury that drags on over weeks or months, and is something that plays in the back of your mind when you take a step or when you get up every morning. It's something that's constantly there. So no wonder it's ringing alarm bells and telling you all about it all the time. So you might be thinking things like, well, why me? Or I just can't do what I want to do. I can't do what I used to do. Am I ever going to be able to do the things I want to do again? Such natural, normal feelings that just a little bit of understanding about pain, about what's going on structurally, about how this can improve and how we can dial down from being stuck up high on our alarm systems. So when we talked to Dr. Marlowe, we were talking about alarm system being stuck up high and how we can gradually start to turn that down, are really, really important. The 3rd and final group was structurally related. So that structural group were generally the older people, 86% of them were obese and 77% were male. Now these had the highest thickening changes on cross-sectional area and really severe restriction in function, i.e. quite a lot of that group, a third of that group, couldn't even do one raise up and back down due to performance, not necessarily pain. So this group needs to be treated in a slightly different manner. Again, a very slow graded strength program is very important, but maybe we need to have a look at other factors that are playing a part in why these tendinopathies might be happening. So I've mentioned obesity a couple of times in those two groups really, the psychosocial dominant group and also this more structural dominant group. Well, obesity is a tricky one, and it's a tricky one because it isn't just about how much weight is going through your tendons when you're walking. It's also about the system change that we have if we are carrying extra weight. Now that system changes, systemic changes inside us, we know that obesity can be related to being a bit more pro-inflammatory. It tends to be related to rises in cholesterol or high blood pressure. And we know that these have an effect on our tendon health. So actually, other things around the outside, any other diagnoses we have like diabetes, anything that's going on in relation to hormone changes with the menopause, all of these have massive links with not just obesity but changes in our tendon health. So it's all well and good telling people to go and do exercise. Well, if it hurts when you do exercise, how can you possibly go and do exercise? It's not going to help any of this. So getting professional support from either a GP or a doctor, a nutritionist, a dietitian and a physiotherapist to work together to help manage those bigger issues, whether that's with medication, whether that's with dietary advice, whether that's with help from pain psychologists like Caroline or other counsellors and things that are going on in lives, whether it's looking more at the nutrition and dietitian side of things and exercise related type of things where we can scale these exercises up for the tendon again, are really, really important. So if anything like this resonates with you today, either things that are changing in your system, things that you've been diagnosed with, or things that are changing as you're getting older, such as the hormone changes in women, or anything that's going on in regards to thoughts and feelings about having this injury for a longer period in time, it is really worth going and speaking to somebody that knows what's going on in those areas. This can really help the tendon management and help that 40% that aren't getting better with just the loaded approach. It's not just looking and zooming in at a tendon. We're not sitting here and just saying, well, I'm only the tendon physio. It's looking at somebody as themselves, as a big picture. And sometimes our health services don't tend to do that. We get sent off to the specialist of this and the specialist of that, and nobody looks at that bigger picture. And it's important that we start to do that. So in summary, what have we learned? We learned that scans tell us about structure, but not about pain. We know that our beliefs and our thoughts can really tell us a lot about our pain and what symptoms we're getting, but not a lot about structure and what's going on. We also know that there's no one-size-fits-all approach to any kind of treatment. We know loading is important and exercise is important, but as Hanlon's explained in his article, there are many other factors that come to play. We need to look at you as a person, not just as a tendon, and help with any thoughts or beliefs or anything that's scary or anything that's making you worried, and help understand that whilst also help rehabilitate that tendon. We know from evidence base that any sort of treatment that's there just really to treat that structure doesn't tend to correlate to how well somebody's going to get on with it and how much they're going to get better. Those sorts of treatments have less evidence base behind them compared to loading and to advice and education. If you would like to find out anything else about Treat My Achilles or book an appointment, please have a look at the links below. Also in those links are to some of the topics that we've discussed today. Thank you very much.